Morning, everyone. Thank you, Shah, for inviting me for this wonderful conference. Uh, I will be presenting my views towards a possible futuristic approach towards diagnostic of erectile dysfunction. I have no conflict of interest, but my aims for this presentation will be intent to approach towards an intent to cure rather than to treat, identification of cellular and molecular mechanisms, and stabilizing the erection homeostasis. Systematic based approach towards diagnosis and targeted therapy, and validation on research based on erection physiology. So, I will be discussing deconstructing erections in such a way which has been for eons with available resources, people have tried to deconstruct it. So whatever resources which I have right now, with my knowledge, I have tried to deconstruct it so that it helps me improvise it. And I would really appreciate your constructive criticism so that I may be able to improvise it much more further. So, I have created a scenario. He's Dr. Mike. He's a urologist or a sexologist, and he suffers from erectile dysfunction. So, his constant questions, which comes in his mind every second of every hour of every day, do you have to take ED meds lifelong? And will it work even consistently? My second question, if I'm a urologist and I'm having an ED, do I have to poke my penis each and every time, and I have to have a penetrative intercourse? Or I have to use a cold penis for penetrative activity? What do you have to get an implant done to enjoy sex? Is there no other solution for it? And can't my sex life be as natural as possible? This is the question which will run through all clinicians who are suffering from the same disease they are going to treat in their clinics. So yes, he will finally keep on thinking, is there a slightest possible for damage control and reversibility, if possible? So here we are. I'm Dr. Fahim from Bangalore. I say restorative therapy is a possibility and future, not regenerative, restorative. Whatever we have to restore it back. So how? Dr. Mike says I need to know everything about it. So by having an algorithm-based management approach towards a restorative therapy. So we have to diagnose first and then step towards the therapeutics. So this is a baby step. So I'll simplify erection. Erection is basically, I'll just play a video. Okay. Erection is basically pumping of blood into the sinusoids lined, into the endothelium lined sinusoids, which I call as balloons, and preventing the egress of blood from the emissary veins, so that the balloons are kept inflated and you get a solid erection for penetrative intercourse. So, if I say, if I have a good blowing capacity, but the balloon is not that elastic enough, it is hard enough, or there is egress of blood through the emissary veins, whatever blood I pump into that cavernous sinusoids, it will not inflate the penis and it will not get an erection. I call it as erectile dysfunction. A similar, one more theory for having an erectile dysfunction is the balloons are very nice, hard and very elastic, but the pumping mechanism is not great. The cavernous blood is not throwing good amount of blood into the sinusoids. So there is no inflation of the balloons. So I call this as arterial stiffness. Okay, so the two main causes which I can see here is endothelial dysfunction. The sinusoids are mainly involved, or the arterial stiffness, where the cavernosal artery is not able to pump that amount of blood to sufficient enough to inflate that balloon or sinusoid. And lastly, with or without tunica albuginea damage for emissary veins to prevent egress of blood. Simplified way. So current guidelines-based treatment rules is the vasoactive drugs, it only works on endothelium-lined sinusoids. Only they will work if they are healthy and they are releasing factors which prevent nitric oxide release. So this is given left, right and center by each and every clinicians. But there is always a catch. It will only work with a healthy endothelium. If it is dysfunctional, it will give poor response, incomplete response, change in therapy, dose escalation, and change in treatment methodology. Or we can go for surgery or devices. For intracavernosal injection, for me, for a reproductive man of any reproductive age group, he has to go to the fridge in the kitchen, get the injection, come back to the bedroom, poke himself, and perform a sexual activity. In this 1 minute walk or a 10-second walk, his desire can go from yes to absolute no. So this, despite me having a good erection grade, the stretch penile length is not that great, compliance is very poor, and these serial escalating dose. Regarding vacuum assisted devices, it requires dexterity. And secondly, it is absolutely not a physiological erection. Most of the patient feels that they are having sexual activity with a cold penis. With the efficacy rate of 90% for sure, but the satisfaction rate is super low, around 30 to 40%. Penile prosthesis, I guess we must be knowing that if there is any loss of any residual erection, it doesn't offer any possible remedy for restorative therapy. Cost is the major factor, especially in India, not covered by insurance. And satisfaction rates, despite it is 85 and 75% with inflatable and malleable respectively, this satisfaction rates will be taken care of. It is 15 to 25%. So that needs to be taken care of. So whatever treatment we are offering at this point of my time on my table as a cafeteria approach, it is only treatment, no cure. I'm just giving Crocin for fever. I'm not treating COVID. Okay? So how I can objectively diagnose ED? By deconstructing ED in my way, by decoding endothelial dysfunction and arterial stiffness, which I call the origin of all cause and effect. This equation is backed up by many researchers. ED is equal to ED. ED is erectile dysfunction is equivalent to endothelial dysfunction, by extension arterial stiffness. These words are interchangeably used, but they are slightly different. So this is based on the fact that penile arteries as compared to coronary arteries are smaller than 1 to 2 millimeters. If I have the same arteriosclerotic burden or penile arteries are much more earlier to get blocked as compared to coronaries. So if a person is getting an erectile dysfunction at this point of time, it means over the next 2 to 3 years, he might be throwing some symptoms regarding coronary artery disease in terms of hypertension or angina or any form of metabolic syndrome he will be presenting in near future. So it can be a target, ED can be a target for future risk for cardiovascular diseases. So, blood pressure was the most easiest and the most available parameter which was used as a cardiovascular risk assessment parameter, but now yes, we have moved beyond blood pressure. Studies have shown that there are structural and functional vascular parameters which are done clinically by most of the cardiologists in terms of carotid and brachial artery diameter, intima media thickness, comprehensibility, distensibility, aortic pulse wave velocity, coronary calcifications. And studies have shown that they are equal in ED patients and non-ED patients. But on few further research, it has shown that if we see endothelial dysfunction in such patients, the endothelium dependent vasodilatation and independent as well as non-independent vasodilatation is much more damaged before showing any symptoms in any of the factors which we see, be it Doppler or Framingham risk score. So how can we assess this endothelial dysfunction as a parameter which should be non-invasive, easily available and reliable? So there is something called as vascular reactivity index. It is a new modality, not super new, but yes, it's a new modality which is used in most of the preventive cardiology, which is principles like change in the fingertip. We have to create an ischemia in an arm and put a probe with the fingertip sensor, and after creating a ischemia, we need to note the temperature changes, because the body is one of the best mechanisms to stabilize, not medicines. So the body will start to maintain the temperature and homeostasis of the end organ, so that it is perfused and it stays alive. So this changes is recorded by this something called as by a machine with a software, and it records vascular reactive index with a temperature graph and a temperature rebound graph, and with software analysis it grades this vascular reactive index as excellent, good, above average, average, below average and poor. So we can correlate this to endothelial dysfunction, because endothelium lined vessels will release some vasodilatory and vasoconstrictive factors, so that the temperature of the end organ is maintained, the fingertip. The same thing is for the penis. So if there is a damage at the end organ, definitely the sinus, endothelium lined sinusoids are also damaged in intracavernously. So arterial stiffness, as we know, aorta is a secondary heart. Despite the blood is pumped from the heart into the aorta manages its blood supply to the other parts of the body by stabilizing its distensibility and compressibility, so that the blood pressure is maintained and perfusion is maintained. Despite heart being working, good working, okay working, poorly working, it helps. So it's the secondary heart. So these large arteries, they have something called as elastin and collagen fibers, which are elastic and flexible, and over a period of time, be it lifestyle changes, age-related changes, metabolic changes, all this causes structural changes in the structural integrity, and this secondary heart doesn't help them. And over a period of time, it loses elasticity and distensibility, and there is an arterial stiffness which cause progressive end organ damage and also erectile dysfunction. This arterial stiffness theory, it rivals hypercholesterolemia as a risk factor for atherosclerosis. Precursor of high blood pressure predicting future cardiovascular risk events. And if we are able to reverse this aortic stiffness or arterial stiffness, we might be able to prevent hypertension, diabetes, metabolic syndrome, any diseases related to vascular abnormality. Any disease starts with endothelium dysfunction, be it cancer, be it metabolic, be it inflammatory. If we are able to target the endothelium, we are going to target many things, not only erectile dysfunction. So it's a well-established indicator as of now for cardiovascular risk. So how can we measure arterial stiffness? There are several invasive and non-invasive methods. Invasive methods will directly measure the central aortic pressures and pulse wave velocity, but we don't want a person coming for a lifestyle change, for an erection, I have to send him for an invasive investigation. We have to find something which is non-invasive. And yes, there are many non-invasive investigations, instruments available, where you use a tonometer, with cuff, without cuff, and we change, we record the peripheral changes, and with the help of software, we translate into a central aortic arterial pressures, we pulse wave velocity, augmentation index, which are operator independent and very reliable. So as I have discussed, arterial stiffness and endothelial dysfunction, they go hand in hand. Arterial stiffness will cause progressive endothelial dysfunction, and this progressive endothelial dysfunction will cause erectile dysfunction, which is a risk factor for a coronary artery disease. But at the same time, metabolic syndrome will cause a chronic inflammatory state, impaired regenerative capacity, cause endothelial dysfunction, and again start the cycle. So, this metabolic syndrome via the toll-like receptor 4 pathway, it's a major pathway which will cause release of inflammatory chemokines and cytokines and cause a low inflammatory state in the body, like diabetes, which will cause decreased nitric oxide expression, stimulation of antioxidant system, alpha tone will be increased, causing endothelial dysfunction, and overall it will cause many sexual dysfunction. and that particular body will start degrading. So we have to break this vicious cycle of male sexual dysfunction. So we have conducted a study in our institute where we tested this diagnostic sensitivity of vascular reactivity index and augmentation index in vasculogenic ED patients. So with an aims to assess their sensitivity as a specificity and how bad is it really reliable. So we had around 199 patients, of which 40 patients were having 44 or 40 patients. 40 were psychogenic, so they were excluded. So these patients underwent penile Doppler, Wendy's, Sigma-core. Wendy's is a machine which determines the vascular reactive index, and the Sigma-core which determines the augmentation index. As per the protocol of the machine, it's a non-invasive protocol. We just subjected this vasculogenic ED patients to this 3 tests. The results were, I'll just go fast. Vascular erectile dysfunction is most prevalent was among 31 to 40 years of age. The IAF and EHS score in vascular endothelial dysfunction patients where 40% shows mild to moderate scores, followed by moderate, severe and mild. 67% of the subjects shows grade 2 erection, followed by grade 1. Most of the patients presenting to us will be grade 2 erection, followed by grade 1 and grade 3 and grade 0. Diagnostic sensitivity of vascular reactivity index, it was maximum for above average category, followed by poor, good, below average. Our diagnostic sensitivity for VRI was kind of poor, with a percentage of 47%. For augmentation index via Sigma-core, the ALX was 74% patient shows moderate ALX, followed by severe and normal, and it has good diagnostic sensitivity with statistical significance of 92%. We compared penile Doppler, VRI and ALX, of which shows penile Doppler has an 85% of sensitivity, and we don't do penile Dopplers while giving intracavernosal injection or oral tadalafil. We just have an assessment of a physiological response by giving an audiovisual stimuli and vibration. Vascular reactive index, as I told, 47%, and augmentation index of 92%, with pulse wave velocity has poorest, which is done by most of the preventive cardiologists, has the most poorest diagnostic sensitivity of 17%. Based on this, we further categorized our patients into patients with ED, erectile dysfunction presenting to our clinic. With history, we divided into mild, moderate and severe. And with the penile Doppler, we differentiated into psychogenic, we excluded. Vasculogenic patients were based on Wendy's and Sigma-core. We divided into, if the VRI or Wendy's is abnormal and Sigma-core or ALX is normal, he's predominantly endothelial dysfunction. It means the endothelium line sinusoids are kind of inelastic, or there might be some kind of venogenic influence also. So we categorize at A. The second category is VRI is normal and ALX is abnormal. It means predominantly arterial stiffness, which is category B. Such patients we correlated complain more of, they are able to achieve an erection of almost grade 2 to grade 3, but immediately there will be a fall. They will not be maintaining erection. And the third category is they have both abnormal. They can be combined category C, which we labeled category C. So this was 7%, 51%, and both is 41%. So there were around 44 patients. This was without comorbid patients. Now there are some patients with comorbidities such as diabetes, hypertension, dyslipidemia, and dyslipidemia was one of the most prevalent form of disorder which was present predominantly in our patient of vasculogenic ED. So we have to make sure that dyslipidemia has always been taken care along with whatever treatment which we are offering to our patients. And my final conclusion is, interestingly, arterial stiffness is more prevalent but less severe. Endothelial dysfunction is less prevalent but more severe. And arterial stiffness is more common in vasculogenic ED. Comparatively, augmentation index is more sensitive marker followed by Doppler and vascular reactivity index. Pulse wave velocity has least diagnostic sensitivity. We need advances in the field of sexual physiology to understand molecular factors and mechanism of erection homeostasis. Ongoing research should possibly foster possible next line of treatment for ED. Restorative therapy can potentially aim cure, then treat. And research should be directed towards identification of cellular and molecular mechanisms of erection. As I told you, this is a comparable and reliable parameters as thing, and we should always target metabolic syndrome because if we target metabolic syndrome, the pro-inflammatory cytokines and reducing the chronic inflammatory state of that body, we will be able to target and achieve and reverse everything. That includes male sexual dysfunction, inflammation, any other causes. And the EUA guidelines should definitely upgrade their restorative therapy parameters so that we'll get more information regarding how to standardize our restorative therapies. Thank you.
Erectile dysfunction is a complex phenomenon, but you made it as a very simplified one. So most of them is understand the main causes of erectile dysfunction. So you have made a very excellent presentation. Thank you for your knowledge input to us also.
Thank you.
Thank you, sir.
Thank you, Dr. Fahim. Please.
So, wonderful talk. What restorative therapy, what is the order you prefer? First,
See, restorative therapies, each and every clinic will be offering different mechanisms. There is no standardization. How you have for endourology or any uro-onco. For restorative therapies, we have either platelet-rich growth factors, we have stem cell therapy, we have shockwave therapy. Which one works for which? That's the second part of my study. So all these three categories will be separated, individually given combination of both of platelet-rich growth factors with shockwave therapy and individually. The same cohort will be taken, and the study is still going on, and we are going to figure out which patient will benefit from what. If there is endothelial dysfunction, will PRGF work, or if there is arterial stiffness, will shockwave therapy work, or a combination works, or which patient we have to offer penile prosthesis directly without offering a regenerative or restorative therapy.
one more question. How long you can wait before going for the next level of management in the restorative therapies?
For if we say if a person comes to a clinic with an ED and if he takes around 5 to 6 doses without with a good compliance, and after dose escalation around 6 to 7 doses is considered to be poor response. We have to change our plan of action.
And is there any way to assess or quantify the growth factors in the plasma?
Yes, we have done that. That's the next plan. We are going to present in ESSM in Italy.
Thank you.
So I just want to ask the representative, you want to add anything with this question? For the quantification of factors.
Yes. Actually, we have quantified the growth factors when we lyophilized. We have made this platelet-rich plasma in powder form. So once we make it in powder form, then we can quantify how much is the growth factors, vascular erythroid growth factor, fibroblast growth factor, platelet-derived growth factor in each milligram of that powder. So it is possible to quantify, but not in individual cases. So when we try to get this as a product, when we get this platelet-rich plasma as powder as a product, then it is possible to quantify the growth factors, and then based on the assessment of the patient, we can determine the dose, how much he needs according to the situation. Thank you.
I just want to add one more thing to that. Dr. Vasan sir and his team, they have shown there is a core amount of VGF in ED patients. This is the first level. Now they will be proving that how much VGF is required to address it. Thank you, sir. So please, sir.
So that I guess I might be presenting in the upcoming shot.
Thank you. I request the chairperson to come and appreciate the speaker.
Jangan lupa